is, particularly today, is going to be on pattern recognition, and we're going to do a small talk on prostate MRI imaging, and just so you can get familiarized with the sort of sequences that we do. Most importantly, we are going to be concentrating on unusual, atypical, or subtle presentations of a common condition. That's the key, really. So the acknowledgements are as follows, with StatDX, Radiopedia, and the atlas described there. As described by Dr. Khan, I've been very fortunate to be one of the co-authors for the urology text in Chapman and Akilny, which is obviously going to be referred to a lot in this presentation. Right, so over to the FRCR cases. So candidate 1, can you hear me?
Yes, I can, yeah.
Okay, so we've got this, we're going to start the Viva session now. So we've got a 40-year-old female with flank pain. So please describe what you can see.
Okay, photograph of the abdomen in an adult patient. I can see some bowel loops which do not appear to be particularly dilated. I can see in the right side of the pelvis a calcification, which is homogeneous and well-defined. I can't see any associated biliary gas with this calcification.
Okay, so the liver and the bowel were fine. Okay, carry on.
Yeah. So in this location, other differentials can include a dermoid.
So I'll stop you there for a second, just so I'm not worried about this calcified focus that you're describing. What do you think that is?
It may represent a dermoid, slightly large for a phlebolith. Other vascular calcifications, I don't think it's within the bowel.
Okay, so let's not dwell on this too much. I mean, this is a calcified mesenteric node, if I was to tell you that. So we'll move on from that. Let's concentrate on the pelvic region. What can you see here?
So I can see a subtle area of gas around the bladder, or the bladder outline appears to be, I can see some calcification perhaps within the bladder wall.
Okay, so describe that. What can you see?
So slightly anterior or slightly superior to the superior pubic rami, I can see a well-defined wall to the bladder, which is slightly dense. It doesn't go through the whole bladder, but it's mainly in the inferior aspect. I think this is likely to represent, I can't see it throughout the bladder, so I don't think it's actually gas. It may represent calcification within the bladder itself. And given this appearance, differentials are quite broad. This may represent schistosomosis of the bladder, TCC of the bladder. It may be other causes. Given this appearance, I'd compare to any previous imaging,
okay,
and then a CT for further evaluation.
Okay, so well done. Also, so just as a recap, as what you've said, the descriptive side of things is crucial for all parts of the fellowship examination. So you have correctly described an area of curvilinear calcification, which is just seen above the level of the iliopectineal line within the pelvic region, which broadly defines the outline of the bladder, and it is not associated with any other significant visceral calcification elsewhere. There is this incidental calcified mesenteric node, and as you quite rightly say, the most likely diagnosis in this case is schistosomiasis. Okay. Now, we're going to go on to another case. So tell me what you see here. No history.
So these are selected unenhanced axial CT images through the pelvis. The right kidney appears hydronephrotic with surrounding free fluids. Going further down, I can see a calcified focus in where I would expect the right ureter to be, and I can see significant calcification, which is again curvilinear and outlines the bladder wall. Having a look at the left kidney, I think I can see some cysts, but I can't actually see the left kidney very well. Given this appearance, it looks like there's calcification in the bladder, which is long-standing, with a right-sided hydronephrosis. With the free fluid, I'll be concerned about a calcific rupture with a urine leak. And with this appearance, I would recommend a post-contrast CT to confirm this and referral to the interventional radiology unit for possible nephrostomy.
Okay. And your diagnosis ultimately is what? Sorry.
So the condition in the bladder, I think it's most likely to represent schistosomosis again, or it may also represent TB given the calcification within the ureters, with an acutely obstructed right kidney, which may have ruptured.
Okay, good. Right, so as you've described, there is calcial dilatation of the right kidney, which is moderate to significant. There is part clubbing of the calyces, which is important. The important negative pertinent point, if you'd like, is that there is no cortical thinning. In other words, there is preservation of the renal cortex. There is significant perinephric stranding. There is fluid seen tracking into the perirenal space, thickening of the fascia of Zuckerkandl. There is a burnt out left-sided kidney, as you can see, with no renal cortex there. And within the pelvis, there is circumferential calcification of the distal ureter with luminal and wall calcification noted. Further south, you've got significant chronic bladder wall changes with thickening, with calcification of the bladder, which again is circumferential, and the features are entirely in keeping with schistosomiasis, as you say. This is the same patient with the coronal formats, and you can see exactly what we've described, with a lobulated outline to the left kidney, dilated and obviously not contributing any function. The right kidney, and it's the important thing to note, is that despite the pelvic heliceal dilatation, which is the terminology I would use, has preservation of the renal cortical parenchyma. And this is the calcification as you've described. Referring to Chapman and our differential bladder wall calcification, bladder calcification, sorry, could it be either in the wall or the lumen? And this is obviously referring to the wall. Okay. Next case. So this is a diabetic, sorry, presenting with AKI and sepsis.
Okay, frontal radiograph of the abdomen. The right kidney is surrounded with free gas, which extends into the retroperitoneum. This will be in keeping with emphysematous nephritis. Emphysematous pyelonephritis. I can't see the outline of the left kidney, and I can't see any gas around the bladder. This is a surgical emergency. I would inform the urologist immediately about this finding and recommend urgent urology review.
Okay, so you've described gas around the right kidney. Is there anything else that you would like to describe within the right kidney or around the right kidney?
Yeah, so there's emphysematous pyelitis, and I can see gas in the calyceal system as well as within the pelvis, so it's quite extensive. Mm-hmm. I can't see any gas within the right ureter, so I think it's probably emphysematous pyelitis with emphysematous pyelonephritis and retroperitoneal free gas on the right-hand side. Okay,
so when you talk about the retroperitoneal gas, where is that gas seen to be tracking? Can you see any tracking here, or are you happy with that it's confined to the perirenal space?
It appears to be tracking inferiorly, so towards the right lower quadrant. sort of and in front of the pelvis, this may represent some overlying bowel loops, but I can see mottled gas at the level of L4 and L5, which is in continuation with the kidney as well.
Okay, is there anything else? Are you happy with that? Is that so? I'm the consultant at the end of a telephone. I'm waiting for your descriptive finding of this radiograph, and you've finished, have you?
Having a look at it on closer review, I think that I can also see gas outlining the left psoas muscle, and having a look at the pelvis around the bladder, there appears to be areas of lucency, which is very likely to present gas. So I think there's extensive retroperitoneal gas within the abdomen.
So the gas, so the gas that you've described in the left psoas is clearly there. But what do you make of this? Can you see this?
Yes, I can see this.
And what's that then?
Is that surrounding the fascia, gyrotous fascia around the kidney?
No. So that would be ventral to the kidney and be seen on FAS. What you've got here is you've got air tracking down the retroperitoneal segment of the paracolic gutter of the ascending colon. So, and this is important to note that the ascending and descending colon have a retroperitoneal component, and therefore gas can be tracking down into the paracolic gutter on either side. Additionally, as you quite rightly say, there is gas seen laterally within the pelvic sidewall, and contextualize this with an IUCD device in situ. Okay, so in this context, this was emphysematous pilatus, and this is in keeping with gas in the urinary system. Okay. The differential you can see here, and again I'm referring back to Chapman, and I won't dwell on this, but you can read through the differential list here, because gas can either be in the bladder lumen, wall, or within the collecting system generically. Now this is another example of emphysematous pyelonephritis, another patient, and I'll just go through a quick descriptive overview. You can see significant perinephric air seen within the retroperitoneum. You can see air within the calyces as well as the proximal ureter. There are multiple renal calculi seen bilaterally. There are further areas of gas formation demonstrated within the anterior aspect of the left collecting system. A lot of the air that you would see, generally speaking, within the collecting system, remember, is going to be is going to rise anteriorly, and given the density of air, and therefore is more often seen ventrally within the collecting system here. A further area of gas is demonstrated here. You've got gas inside the bladder, and this is consistent with emphysematous pyelonephritis, which is widespread and affecting both systems. Right, next case is a 70-year-old male. Just tell me what you can see in terms of calcification, please.
So there's calcification of the seminal vesicles. Sorry, the vas deferens. So calcification of the vas deferens, I can't see, and there's some phlebolysis in the right hemipelvis. I can't see, the most likely cause for this would be diabetics.
Would be a diabetic patient, okay. And how do you think they would present with vas deferens calcification?
How they present? I think they're usually asymptomatic.
Okay, so they can present with no symptoms at all, and this could be an incidental finding, but they can also present with hematospermia. And the reason why we've shown you this is because of the vas deferens calcification has come up in the fellowship examination, so it's worth knowing what it looks like. Right, next case, we've got a 45-year-old female who is immunocompromised and is complaining of dysuria.
Okay, so frontal radiograph of the abdomen in a 45-year-old immunocompromised lady. In the left hemipelvis, adjacent to the ileum, I can see a oval structure with gas surrounding the wall. I can see some small bowel loops which have a non-specific bowel gas pattern.
Where specifically are you looking at, sorry?
So I'm looking at in the left hemipelvis, there appears to be an area of lucency. Having a look in the actual hemipelvis itself, in the bladder, there appears to be gas surrounding the actual bladder wall itself, with a curvilinear area of gas with a significantly dilated bladder. I can also see some surgical clips in the left upper quadrants. The bowel gas pattern is non-specific. I can't see any free abdominal gas. This would be in keeping with emphysematous cystitis.
Okay. So, as you've said, there is a curvilinear area of gas demonstrated, which is outlining the bladder, as can be seen within the pelvis. The bladder is clearly distended, and the ear, once you have seen it within the bladder, you should always look upstream to the collecting systems to ensure that there is no gas tracking up into the upper tracts, and in this case there isn't. So the features are completely in keeping with emphysematous cystitis. Generally speaking, gas in the bladder wall only has a single differential, and it's worth referring to Chapman to review this in further detail. Now, this is an IVU examination, and a lot of centres, in fact most centres in the UK, don't use IVUs at all now. But can you get an IVU in the exam? And the answer is yes, you can. So it's worth having a handle on what sort of IVU films there are and what you're trying to look for. So I'm going to give you this image, and this is a plain film on the left, and the one where it says IVU is a 10-minute excretory phase study, and you can vaguely see a bit of fullness of the collecting system on the left side, and you can see a nephrogram on this side as well, and you can similarly see the appearances on the right side. And so there may be a little bit of fullness of the left kidney. Can't really see a renal calculus. Now, same patient, this was a CT of the non-contrast CT of the kidneys, and you can see the collecting system indeed is slightly dilated. There is a calculus seen here within the inferior calyx, and there's a further partially obstructive calculus in the proximal ureter. And the take-home message is that although plain films and IVUs do have a role, CT-KUBs have largely superseded, and CT urograms have superseded IVUs because of their sensitivity to pick up things like stones. Now, this is another case, so please describe what you see.
So this is an intravenous urogram, which is 15-minute delayed. In my routine practice, I would first compare to the control radiograph.
Good. Control radiograph was normal. Thank you.
Okay. So having a look at the ureters, I can see both ureters have been contrast opacified. They pass through the normal expected location for the ureters and not displaced, and I can see them filling the bladder. On the left-hand side, I can see a expanded ureter within the bladder in keeping with a urethroseal. It's not causing any significant obstruction or reflux. I would do a more delayed IVU to check if they have a duplex system on the left-hand side, because they can be associated with urethroseals.
Okay, so you would do what? Sorry, I didn't catch that.
and more delayed. I can only see, I can't see a duplex system on the left, but I can see a urethrosil in the bladder on the left-hand side.
Yes. Okay. So what's the descriptive term used for that? Do you know what it's called?
They call it cobra heads.
Yeah, exactly. So it's a cobra head sign. Urethrosil's, you're absolutely right. So urethrosil seen there as a filling defect within the bladder. Occurs in about 1 in 5,000 to 1 in 12,000 children, and usually seen largely in the Caucasian populations. And females are more commonly affected than males, as you probably are aware. There is, if you've got a urethrosil, then there is an affiliation or a connection with other congenital urinary tract abnormalities that you need to be aware of. And urethrosills can either be intravesical or extravesical. Where do you think this one is?
Intravesical.
Intravesical, good. Okay. So, but if it was to be extravesical, where could it be? I mean, where is the common site of ectopic insertion, if you'd like?
Ectopic insertion. So I know they can insert in the ureter. Sorry, in the uterus is one location.
If it was, if the ectopic insertion was inside the bladder, where could it be? Would it be medial or lateral to the BUJ on this side?
Lateral.
No, it's medial.
Okay.
So it's usually more towards the midline, and so it's just worth bearing that in mind. So if you see something like this and it's out of line with the normal line of projection of the ureter, you need to just think about an ectopic urethrosil. Now this is another patient. This is a sagittal and transverse cuts through the bladder with an ultrasound, and you can see a filling defect just demonstrated here, and this nicely demonstrates the urethrosil, as you can see there. Right. Next case, what do you see?
So there's bilateral renal calcification in keeping with, it looks like it's medullary-based calcification, bilaterally more so on the left than on the right-hand side. Differentials for medullary calcification include medullary sponge kidney, renal tuberculosis, and hyperparathyroidism.
Good. So what's your diagnosis here then?
I think it's most likely to present medullary sponge kidney.
Okay, so we've got a classic example of a medullary sponge kidney, and as you say, this is medullary nephrocalcinosis. So this is a spot diagnosis, really, isn't it? Now, we've got another case here. This is a 30-year-old male who has bilateral flank pain and hematuria. Do you see any nephrocalcinosis on this on these ultrasound series?
So in the lower images, I can see some hyperechoic foci within the cortices, more so on the lower left image. I can't see any convincing acoustic, posterior acoustic shadowing. And if I have a look on the right image, I think there are some areas of hyperechoic foci, but again, I can't see any posterior acoustic shadowing. I think this would either represent calcification or possibly fat, but I'm not sure which one.
Okay, so slightly more subtle, isn't it, the changes that, and where would you say the changes are?
In the cortex.
Okay, so you think it's in the cortex. Okay, let's just, what would you do now?
So given that I found this finding, I'll first check if we've had any previous imaging, and if not, then probably would recommend the CT for a more definite diagnosis.
Okay, so we have the CT. Is this MSK?
No, it's not MSK, no. It appears to be faint, subtle calcification within the cortical-medullary junction. So this is more in keeping with cortical calcification rather than medullary calcification.
And why do you say that?
It appears to be predominantly centered in the cortical medullary junction area, and it doesn't appear to be very diffuse, slightly faint in appearances as well. So I think
Right.
it's less likely to present medullary calcification.
Okay. So if I was to point out the calcification here being just above the convexity of or the concavity, sorry, of a calyx, where would that be? Similar appearances here. What would that location be known as? Is this medullary or cortical, therefore?
I think if it's outlining the calyx, it'll more likely be medullary.
Correct. So this is medullary nephrocalcinosis. Just as a reminder to me, cortical nephrocalcinosis more or less common than medullary?
Cortical is a lot less common.
Okay. So cortical has a shorter differential, doesn't it, in terms of what the differential diagnostic possibilities are? Do you know, can you name two of those differentials possibly now that you've mentioned cortical?
So you can get it with chronic glomerulonephritis and chronic infections, and
Okay.
it can also be associated with conditions like Alport's.
Yeah, Alport's, alkaptonuria, oxalosis. Okay, so these are the genetic chemical-related disorders that can cause cortical nephrocalcinosis. Medullary obviously has a wide range of differentials. Now, this is the same patient, and the patient indeed did have medullary nephrocalcinosis, and it was thought to be secondary to hyperparathyroidism. And in this case, the parathyroid adenoma was actually sited inside the thyroid parenchyma. You can see the carotid artery there, just to familiarize yourself in terms of the anatomy. And this is the outline there. And this is the MIBI scan, in which also shows and confirmed the presence of the parathyroid adenoma. This is the differential for nephrocalcinosis, and it could be medullary or cortical. And in this case, hyperparathyroidism has come up in the exam setting and is the second most common cause of medullary nephrocalcinosis after medullary sponge kidney.
Excuse me, Imran. We'll go to candidate 2 now. Candidate 1, thank you very much. Imran, can you hear me?
Yes, I can, sir.
So, candidate 2, can you please raise your hand? Yeah, I can see you now.
Hello?
Yes, we can hear you. Thank you, candidate 1. Imran, over to you, please.
Thank you. Hello, candidate 2.
Hello.
Right, so what we're going to now talk about is we're just going to go through prostates and prostate imaging. So this is but before we do so, I'll show you this film as a Viva film. This is something that's come out of our archives from 1973 from Basildon itself. Can you describe what you see?
Yep, so this is an intravenous urogram for a 67-year-old male. I can see an abnormality in the centre around the midline, just inferior to the bladder, which is causing a rounded impression of a filling defect on the inferior surface of the bladder. The bladder itself also appears slightly trabeculated with a lobular outline, and the collecting systems do not appear obstructed. So the trabeculated outline and the filling defect would make me suspicious of an enlarged prostate, possibly causing secondary outlet obstruction with chronic changes seen in the bladder.
Okay, and just do you see anything in the bone?
In the bones, yes, on review of the pelvic bones, I can see multiple sclerotic foci in both iliac wings and also possibly in that left proximal femora.
Okay, so
So that would,
put it all
yes,
together.
that would make me suspicious of a prostatic malignancy with metastatic disease, possibly.
Okay, so good. I mean, this is just as a teaser, really. I mean, it's an old film. It used to be the way before, you know, in the good old days, how prostate cancer was diagnosed. I mean, you can see multiple bony metastases, sclerotic in nature, some of which are more confluent. There is partial distension of the right collecting system. There's a filling defect outlining the bladder, and you can see a trabeculated pattern as you've described correctly, and the features are consistent with disseminated prostate cancer. Now, we're going to go through multiparametric MRI prostates. The prostate imaging nowadays is obviously centered largely on multiparametric MRI scans and gives you a weighted scoring system of how likely or unlikely you are to have prostate cancer. And this usually relies on a combination of three things: 2-2 weighted imaging, DWI sequences, and contrast enhancement. And the combination of which is then brought together, and the scoring system is then is introduced. And this is based on the system called the PIRAD scoring system, which we'll just briefly touch upon, and the current version that's being utilised is utilising contrast enhancement. I'm going to concentrate mainly on T2 weighted imaging, however, because contrast enhancement doesn't necessarily come up in the exam at the moment, but it's the T2 weighted imaging that we're interested in. And what tends to feature are tumours in the peripheral zone, whether there's capsular breach or not, seminal vesicle invasion, nodal involvement, and bony metastases. Now, the typical sequences that are utilised for multiparametric MRI imaging is we use a T2, you can see here, T1 large field of view for the abdomen. T2 sagittal sequences are important. We use a DWI sequence as well as the ADC mapping. We use a T1 large field of view for the pelvis as well as a small field of view. And stay off the imaging is this: it's the T2 small field of view for the pelvis and the prostate, and we use coronal imaging as well, and this is largely used for nodal definition. The addition, if you'd like, is a dynamic contrast enhanced imaging, which essentially are multiple sequential measurements, and this is important, that are taken post-contrast at 10 seconds intervals, and that defines the dynamic contrast enhancement nature of the prostatic parenchyma, and anything that shows early enhancement is indicative of something inflammatory or malignant. Now, this is a Viva case. It's a 64-year-old male with a raised PSA. What do you see, please?
So on the selected axial T2 weighted images, I can see in the right peripheral zone there is an ill-defined area of low signal posteriorly, which is extending beyond the capsule with ill definition laterally, and perhaps posteriorly as well, but I'm not entirely convinced that it's reaching posteriorly to the rectum. I would obviously scan up and down to assess this further, as well as reviewing the sagittal images. On the selected sequences, images rather, I cannot see any suspicious appearing lymph nodes, and would obviously assess the bones in the field of view on the T1 image. So in summary, I can see a suspicious area of altered signal in the right posterolateral peripheral zone. I'm not confidently able to say exactly where it is in the prostate gland, at which level I mean, and I would also confirm these findings on the DWI and ADC maps.
Okay, good. So in essence, we've got a T2 weighted axial small field of view image, and as you say, there is an area of nodular change seen in the right peripheral zone base. The nodularity and the low signal change that you can see is at the 7 o'clock position, so it's well worth getting a clock face if you'd like, similar to the perianal fistula imaging that we use using a clock phase. So use that. That's 7 o'clock. You've got linear pericapsular striations. Do you see that? Linear and perpendicular to the capsular margin, and therefore this is indicative of a probable. Now, obviously, this can't be said in isolation, but the features here are suspicious for a potential malignancy with a raised PSA, and therefore this would be a possible T3A process here. And in terms of cancer imaging for the prostate, this I think is a really important slide, and I think we need to get a grip of this. For the exam, particularly at this level, T3 definition is very important, and you need to be able to define whether the disease has breached the capsule. But also the other feature that is important is the subdivisions of the T2. So if you've got T2A disease, that means that you've got involvement of 1/2 of one lobe or less. T2B disease involves more than 1/2 of one lobe, and T2C is both lobes, and it's a very important way of allowing the clinicians to know that you understand the disease extent volume-wise within the prostate lobes themselves. T3B is seminal vesicle involvement, and so the T3 division is only A and B, and T4, obviously, just like any other malignancy, involves adjacent viscera. So, question to you, is there a tumour? Is there any capsular breach? And these are two different cases, so you can refer to them as case 1 and case 2, please.
Okay, so in case 1, I am suspicious that there is a tumour with low T2 signal in the peripheral zone and ill definition laterally on the left. So yes to tumour and yes to capsular breach. In case 2, I don't think that there is tumour.
Okay.
Yeah.
Right. So, so again, remember what we've said, and what my what I emphasise is descriptive abilities, and that's key. So, and this is to all the candidates that are listening. I mean, I'm particularly keen for you to be able to describe something such that at the end of a telephone call, I know what you're talking about as your consultant. And so to this end, we'll describe what you've just said. So there is an area of wedge-shaped low signal change on the T2 weighted sequences between the 9 and 7 o'clock position on the right side, and between the 3 and 5 o'clock position on the left side. The capsule appears to be stretched, and there's a possible ill-defined linear focus here, but whether that's capsular breach or not would need further imaging. Case 2 shows capsular bulging, and that's a term that we're using here. That's a particular term for prostate imaging. Capsular bulging with mass effect. You can see an elliptical nodular focus here, but the capsular margins appear to be maintained. Okay. So, so I would say possible T3A, T2 on this side. Right. Another Viva case, 2 different cases. What's your finding, please?
Okay, so in case 1, there is an area of low signal occupying most of the right peripheral zone, which is asymmetrical when compared to the left, appears smaller. There is irregularity of the capsule on that side also, and possibly some linear low signal extensions laterally at the 7 to 8 o'clock position. In the right clinical context, I believe these findings would be suspicious for a T3A tumour. In the second case, in the left peripheral gland, there is low to intermediate T2 signal in the left peripheral gland, extending from probably the 3 to 6 o'clock position. This, I believe, is extending beyond the capsule, where it's very ill-defined, and the signal changes are extending into what I think might be the adjacent seminal vesicles, which are of a similar signal.
Okay.
So that would be, if those findings were correct, obviously I'd confirm by looking through the rest of the images, but if those findings were correct, I'd grade that as a T3B.
Okay. Right, so just to go through that case, on the right-hand side, you've got, so description, remember descriptive tendencies are important. You've got a serrated margin to the right peripheral zone base. So this is important, is the volume of the prostate. You can see it's the volume of the prostate means that we're still into the base of the prostate. So in terms of zonal anatomy, we can the base of the prostate is at the top, so it's not the base referring to the bottom. The apex is referring to the bottom of the prostate, and here we've got a large amount of the prostate seen, and therefore this is at the top of the higher end of the prostate, and therefore this is still the base. So a serrated nodular margin, which is contiguous with a soft tissue, with a lesion, seen within the peripheral zone. But I can't see the linear pericapsular striations that we've described before for tumoral extension beyond the capsule. So possible, but a serrated nodular margin, which is close. Now, the other thing that you need to know, and this is a distinction between the two cases, and this is important, that you can see the normal capsular bulge of a normal peripheral zone here, correct? On the right side, however, the capsular margins have been retracted, so there's a retractile effect from this tumoral focus. The case 2, which is deliberately been shown, on the other hand, shows a bulging effect of the pathological side, and the normal side shows a normal capsular margin which is not retracted, but it's in its normal position. So it's worth knowing that tumours can also cause a retractile effect as well as causing nodular bulging. And this was indeed a T3A process, as you described, not T3B.
Okay.
Right. We're just going to be going through prostate anatomy now. So just for those of you who are not familiar with prostate MRI imaging, so we've got an axial T2 weighted sequence that we're just showing at the moment, and what we're doing is we're scrolling south, and you can see here just in the background on either side you've got the seminal vesicles coming in, you've got the rectum here and the mesorectal fascia. You've got a slightly trabeculated bladder in this case, and there's the prostate that you can see here with the peripheral zone just seen there. That's the capsular margin just well demarcated there. So the rectum and the prostate, the interface needs to be defined. So what's important in MRI prostate imaging, particularly when you've got evidence of possible tumoral spread, is to talk about the rectoprostatic angle, because that preservation is crucial in terms of the disease management of the patient. Obviously, what's important is the seminal vesicles as well. And what's also important is defining your nodal places of nodal involvement. So where could the lymph nodes be? Well, So I'm just going to go through this as a thumb sketch now. Lymph node involvement in prostate cancer imaging in terms of pertinent negatives to mention. So it could be periprostatic, it could be perivesical, it could be pelvic side wall, obturator within this region here, presacral, or along the iliac chain. So always look up the iliac chain as well. Okay. Now in this case, there are no lymph nodes. This is a normal MRI prostate. This is a sagittal sequence, and what's important to do is go back and forth, and you can see the prostate here. Now, in terms of the prostate volume measurement, so the way I define prostates in my imaging, I look at the prostate volume, and the way you do a measurement should be an AP, and so I'll just go back to the previous here. An AP measurement here, an transverse measurement here, so AP times transverse times a long axis, and this is the way I refer to it, a long axis along the sagittal plane, and the multiplication of these three orthogonal planes times 0.52 will give you a prostatic volume. Now the importance of a sagittal sequence is seen very early on, because if you've got tumoral extension from the capsular margin, it's one of the ways that you can define whether the tumor is indeed infiltrating the seminal vesicles. In the midline, you have the point where the seminal vesicles meet in the midline, and that's called the genu, as you know, of the seminal vesicles, and that's often a place where tumoral involvement can occur, and that's a T3B process. The other thing that a sagittal sequence will allow you to do is define your median lobe. Median lobe projection into the bladder, and also whether you have visceral invasion of the bladder neck. That's very crucial as well. So get into the mode of looking at the sagittal sequence for definition of whether there's visceral invasion of the bladder, whether there's seminal vesicle involvement, the definition of the seminal vesicles, and look for symmetry on either side. As the seminal vesicle comes down, it tapers down, and that tapering effect should be present. If that tapering effect is gone or blunted, then that implies that you may well have a malignant process that's infiltrating the base of the seminal vesicles on either side. Okay, look for symmetry. You can look at the vas deferens as well on either side. And also the other advantage of the sagittal sequence is the definition of the posterior prostatic wall with the anterior rectal margin, and therefore definition of the retroprostatic angle that we've referred to. The sagittal sequences are also referred to for lymph node involvement, although in my personal practice I use sagittal or coronal sequences. So the coronal sequences I find are very good for an overview of where the lymphadenopathy is, and for me that seems to be something that's very important. Now, for those of you, if you do prostate imaging or have seen prostate imaging, you often see a central median lobe, which is a common finding that projects into the bladder lumen, and that is a common feature of BPH, as we all know. The rate of malignancy in a median lobe is incredibly low, so prostate cancers very rarely affect the median lobe. So you may well see features that appear to be pathological, i.e. restricted diffusion on the DWI, but this is a take-home message that median lobe tumours are incredibly rare. Okay. This is a T1 weighted sequence, and this is useful in terms of the mapping of the bony pelvis and to look for any evidence of signal change within the bone marrow, to look for prostate cancer metastases, so sclerotic metastases. Here we've got heterogeneity of the bone marrow, but no bony metastases are seen here. And the other thing that we look for on a T1 weighted sequence is whether we've got hemorrhagic change, particularly within the seminal vesicles, for instance post biopsy or related to hematospermia. This is a large field of view of the abdomen, and we often incorporate T2 weighted sequences as matter of routine in most prostate imaging. So if that is asked of you in the exam, is there any point in doing abdominal imaging? Yes, there is, and it's T2 and T1 large field of view. And what we're looking for is any evidence of, I don't like to say hydronephrosis, I like to say pelvic helicil distension, because I think that's more specific a term. Hydronephrosis is, in my opinion, is an overly used term. There's here you can see atrophy of the left kidney, normal appearance of the right kidney. This is important. Excuse me. And the other thing that we look for is any evidence of retroperitoneal lymphadenopathy. Okay, and that's the reason for doing the abdominal imaging. Now we're going to talk more anatomy now. So I'm going to use the image that we've had in the one of the first cases. This is calcification of the vas deferens. Now, how does that define us or help define anatomy? Well, in this case, this is the corresponding MRI scanner. You can see how the calcification of the vas deferens has helped define them very nicely. You can see the mesorectal fascia here. You can see the mesorectal fat planes very nicely. And you can see that in most men, the vas deferens comes in medially, and you can see that it joins the genu of the seminal vesicles on either side. So the seminal vesicles bulky, coming in, and they immediately join. So that's the let's go back. That's the tip of the seminal vesicles, and these are the tips of the vas deferens. So they're joining. So if we come back out, the vas deferens here, they come here, lying on the mesorectal fascia, the fascia of Denonvilliers. It does a U-bend and then starts to move ventrally. And you can see the calcification has also helped in terms of defining the path of the vas deferens. They move medial to the iliac vessels, and then they move laterally. And that lateral movement is very important, and you start to now see the early formation of what is the spermatic cord, and that then goes through the inguinal canal just here, and that vas deferens then continues into the inguinal canal into the scrotum. Okay, so calcification sometimes can help in terms of anatomical definition, and so I hope that was a useful delineation of the vas deferens as a whole. Now I'm going to show you a pathological case now, and this is a patient with T3 cancer, N1, M1. So let's go through this. So axial T2 small field of view. Remember the mainstay of our imaging. And you can see a large mass effect crossing from the peripheral zone base between the 3 and the 6 o'clock position, and it crosses the interface of the transitional zone prostatic peripheral zone interfaces, the PZ-TZ interface that is now being breached by this large mass effect. There is also some further nodularity seen to cross the midline. And look what we can see here. You can see pericapsular tumoral breach into the periprostatic fat planes, with further breach seen on the right side. Okay, so there's evidence of tumor spread, and this is very nicely seen on the T2 weighted sequences. The other thing that you can see here, I don't know whether you can see that, but the levator ani muscle on the right side is fine, but the left side there's an acute angulation. So instead of having that broad curvature, you've got this acute angulation that's been formed, and this is because of tumoral invasion of the periprostatic fat planes, which is causing mass effect locally. So, so we've got a tumour that's clearly spreading outside, and the question then is it invading the seminal vesicles, and what else is going on? Well, this is in the context of a trabeculated bladder, and that's not surprising given the prostate size. And also additional to that, you've got this perivesical tumoral nodule. Now, the difficulty here is this is not typical for a lymph node to be located, because the lymph node locations, as we said, was peripheral, side wall, obturator, presacral, and iliac. But if you do get something here, this could be either a tumour nodule itself or indeed a lymph node. So it's worth bearing that in mind. Now, the sagittal sequence, as we said before, is used to define seminal vesicle invasion. So you can see the tumour here, and you can see that the demarcation of the seminal vesicle is very well demarcated on this side, as well as this side here, it's well demarcated. So although potentially there is tumour abutting the seminal vesicle, it appears not to be necessarily invading it. And there's no invasion of the bladder neck, but the bladder is seen to be trabeculated. The other things that we can see on the sagittal are the lymph nodes, and then we start to see changes within the sacrum as well, and these are things that we can define further through a T1 sequence. Now this is the coronal sequence that I use to further validate any axial imaging showing lymph nodes, and here you can see very nicely large conglomerate nodal changes bilaterally, okay, in the context of this tumour. So, so we've got a, contextualizing this, we've got a T3 tumour which has breached the capsular margins, and we've got lymphadenopathy. So we've got T3A N1. Now, let's have a look at the T1 weighted sequences, and immediately you can see a sclerotic focus just seen there in the inferior pubic ramus on either side, and just anteriorly there on the left. And the features are obviously of concern for sclerotic prostatic metastases. Now, same patient, and this shows the significance of T2 abdominal imaging, and as we come south, you can see a bit of fullness of the kidneys on either side, and as you come south, left paraortic nodal changes, and there's multiple lymph nodes that are visualized, and therefore that indicates here as well, for example, that the degree of spread of the disease is beyond the pelvis into the abdominal cavity. So that was a T3A N1M1 disease, and that's the TNM classification. This is another example of prostate cancer imaging, and in this context, we've got to, again, start off with our axial T2 small field of view, and you've got a large mass effect here. There's a tumour, low signal change, and look at the proximity of the rectum with the posterior aspect of the prostate. There is tumoral extension seen laterally, posterolaterally on the left side, and there appears to be thickening and nodularity crossing the anterior mesorectal fascia. Okay. Now, also the other thing here is that you can see this appearance here, where there's eccentric thickening, curvilinear on the left-hand side. So we need to see whether there's any visceral invasion of the bladder neck. Now let's have a look on the sagittal sequences of the same patient, and here you can see a trabeculated pattern to the bladder. You can see here that there is tumour extension into the seminal vesicles. If we just go back here, this is normal rectoprostatic fat plane, and this has been breached here, and there is tumoral extension into the anterior aspect of the rectal wall. The other thing that we can see here on the sagittal sequences at times is the lymph nodes. The lymph nodes here are seen here, for example, at the level of the iliac chain. And then these are the coronal sequences, which then further validates or disclaims or excludes lymphadenopathy, and you can see them quite nicely here. So remember, coronals are there to validate or exclude lymph nodes that you've seen on the axial imaging. So all in all, this is a T4 tumour, and the baseline imaging of the axial, as shown here, has demonstrated rectal wall and bladder invasion, and the rectal involvement is subtle, but you can see these stranding, these areas of changes just seen within the anterior rectal wall, and the features are therefore those of T4 involvement of the rectum as well as the bladder, as you can see just here. Right, so that's the prostate sequences done. So we're going to now resume the rest of the viva cases. Given this persistence of change, signal change on the DWI sequences, and the peripheral rim of enhancement is a focal prostatic abscess. or a focal area of prostatic inflammation. But in this case, it was a focal abscess. But well described. But I would just commit a little bit more and note there are two T2 weighted areas of nodularity. So anything high signal on T2 with restricted diffusion is likely to be inflammatory until proven otherwise.
Okay.
Now, oops, sorry. So this is the list of lesions that you could come across, and this again I'm referring back to Chapman. They could be solid or they could be cystic, and what we've been referring to is obviously an abscess in this particular case. Right, so now next survivor question. We've got a 77-year-old male, and the patient has fever, and I'd like you to go through this and see what you think, please.
Okay, so on these selected contrast enhanced axial, sagittal and coronal images of the abdomen and pelvis for a 77-year-old male, I can see an abnormality in the second and third axial images in the urinary bladder, which is fairly well distended and appears circumferentially thick-walled, possibly with some degree of enhancement, and anteriorly there is a large locule of gas. There's no catheter that I can see within the bladder that would account for this, so I would be suspicious of a more worrying etiology elsewhere.
Okay, can I just stop you there? So,
Yep.
You've described a large locule of air. Have you described whether it's within the lumen or the bladder wall? Have you described?
I haven't yet, but I think it's within the lumen itself, because I think that I'm fairly confident that I can see an air fluid level within the lumen of the bladder.
Agreed.
On the sagittal image, there is another smaller locule of gas just on top of the dome of the bladder, but I think that might be within a within a bowel loop.
Correct.
On the selected images of the kidneys, I can't see any pelvic-calyceal dilatation or any significant perinephric stranding.
Do you see anything? Let's just go back into the pelvis. What else do you see?
I think that there are some enlarged right pelvic sidewall lymph nodes.
Okay.
I think just posterior to that right.
So basically, what you've got is you've got a trabeculated, thick-walled bladder.
Yep.
Do you think that there is any evidence of any perivesical inflammatory ground glass stranding that you can see?
Yes.
Yes. So there's an element of that, correct?
Yeah.
So any ground glass changes that you can see potentially could relate to an inflammatory process. And then also, what's your opinion of the prostate?
It appears quite heterogeneous.
Good. Okay.
Yeah.
What else do you see within the prostate in particular? Do you see anything at all?
Within the prostate itself, there's sort of punctate areas of low signal and peripheral enhancement.
Yeah, so there is heterogeneity of enhancement. Perhaps we can't draw too many conclusions. Sometimes we can with the CT. But on this occasion, there appears to be an involvement of the prostate, at the very least. There may well be a prostatic abscess here that you can see just at this point.
Yep.
You've got thickening and trabeculation of the bladder, and you've got perivesical stranding. So put that all together.
So these findings with the history of fever and dysuria would be in keeping with an inflammatory process, likely infective, possibly a prostatic abscess with secondary cystitis.
Okay, good.
The other way around.
Oh, sorry. So this is an inflammatory process affecting the bladder. So you've got some sort of granulomatous cystitis with and obviously anything that becomes inflamed in terms of the visceral invasion of or involvement of the bladder can backtrack and involve the prostate, and therefore there's two visceral organ involvement, and that's the key here. So the pathology is one is intimately related to the other, and that's the take-home message. And this may well turn out to be, at the very least, a prostatitis, but at the worst, it could be a prostatic abscess related to an inflammatory process related to a trabeculated thick-walled bladder. Okay. Please remember to feed back on a regular basis. So that was there as a reminder to all of you. Now, we're going to go on to our next case. This is a 42-year-old male, and they presented with abdominal and flank pain, sudden onset of gross hematuria. Please talk me through what you can see.
Okay, so these are non-contrast, delayed contrast enhanced, and I think urographic phase images. On the non-contrast images, I can see foci of calcification in the left kidney, which I think are within the collecting system and possibly some are more cortically based. On the urographic phase, I'm not sure if this is because of the slice that we have, but there's no contrast within the left pelvic adacil system.
Okay, so let's just because we're running short of time, just going to go through this. I mean, you've got plain CT, you've got some punctate areas of calcification that you can see here. And then suddenly on this, you've got a nephrographic phase on the CT, and then you see this dilated segment here, right?
Yeah.
Okay. Of this, and this is at the level of the medulla, correct? Now, this is further seen here. You've got what description would you say that? What does that look like here on the urographic phase? It's like a claw, correct?
Yes, so like
there's
a
a claw,
defect.
correct. There's a filling defect and there's a claw appearance here. This is another appearance here. And what's that appearance called? There's a filling defect in the middle of that. And you've got further filling defects. Sorry?
I can't remember the name of it, but I can see that there are filling defects with contrast more peripherally around it.
Exactly. So before we carry on, or before we go into into what this is, I'm just going to run through some anatomy with you. So this is a cross section of the kidney. Very crudely, you've got the cortex and you've got the corticomedullary junction here, correct? Okay, we talk about the corticomedullary interface, don't we?
Yeah.
Now, if you look here, you've got the medulla, which constitutes this triangular segment which feeds into the kidney and into the collecting system. And at the tip of the medulla, you have the papilla. So that's the papilla, and this is the pyramid appearance, so-called, referred to because of the pyramid shape of the medulla. So the medulla are segments of functional anatomical sections, which is a functional driving machine of the kidney. Now the papilla floats into the renal, into the calyx, and so that's important, okay? In between, you have normal interspersed areas of renal cortical tissue, also known as the renal column of Bertin. That's interspersed, and sometimes they can be hypertrophied. Okay, so but at this on this talk, we're talking about the renal medulla, and these are the phases of contrast CT, and we're just going to show you what I mean by that, the differential contrast enhancement in terms of nephrograms and so on. This is a non-contrast CT, it's a faint area of calcification. Here, this is a arterial phase, and the arterial phase is very good for definition of the renal cortex, okay? In contrast, the medullary pyramids appear to be low attenuation and have that sort of inverted triangular appearance. Do you see that? Okay, and that's typical. You have a division of major and minor calyces, and we can see the major calyces are obviously larger than the minor, and then the renal papilla, as we just talked about here, are the apices of the pyramid which fold into the collecting system. Now this is a later image where the venous phase has started occurring, and you've lost that corticomedullary interface, and that's become one, hasn't it? And this is and from then you go on to the excretory phase where the renal papilla or the medulla have filtered their chemicals and the material and the urine into the collecting system, which is why you've got the urographic phase. This is a three-dimensional volume rendered imaging. It shows multiple renal pyramids which are centered around the collecting system. So there's an intimate relationship between the two. Now, as you can imagine, if one pathology affects the renal pyramids, it will then filter in and slough off into the collecting system. So this is another example of a anatomical outline of the collecting system, outlining the minor and major calyces, and shows the urographic or the excretory phase of a urogram. Now, what we were referring to in the images on the CT was renal papillary necrosis. So what do you understand from renal papillary necrosis?
So it's a result of ischemic necrosis, and you get faint sort of filling defect in the contrast enhanced phase.
Yes. Okay. So, and are you familiar with the signs? So the signs, and this is important because the renal papillary necrosis is referred to as sloughing of segments of the medullary pyramid, and this is a very good diagrammatic representation where some of this filters and sloughs off into the collecting system, and therefore the contrast on the residual aspect of the renal medullary pyramid is what's left behind, and that creates the claw, lobster claw sign after the residual sloughing has already occurred into the collecting system. This is the ball on T sign, and this is literally just almost looks like a singular focus on top of a blunted calyx. Do you see that appearance there? You can see these appearances, and these are very classical, not quite pathognomonic, but fairly typical for renal papillary necrosis. And it's the sloughing effect that you get. Now remember, if you've got a back pressure into the collecting system, what happens to the calyces? They become clubbed. Now this is the end point where the calyces are where you've got severe hydronephrosis, but somewhere in between you get this effect here. So instead of the fornices, which are the outline of the concavity of the calyx, if that becomes blunted like it has here, that means that there is fullness of the collecting system from whatever outflow obstruction that you have, and that backfills and pressurizes the medullary pyramid, and you start getting an ischemic necrotic effect, which then sloughs off parts of the medullary pyramid into the collecting system, which gives you the signet sign, clubbed calyx, depending on the type of sloughing and where the pressure effect is felt in the renal medulla. Is that clear?
Yes. Okay.
So I know we're running short of time, but this is another an example of a back pressure effect. The calyces are clubbed instead of having their normal concavity, and you can see that's had an effect, pressurized effect on the medullary pyramid, which is sloughed off, and you then start to see a separation of contrast from the collecting system as it starts to filter and slough off into the calyces and the infundibuli. And here, this is an example of the residual contrast that is seen once a sloughed segment of the renal medulla is left behind. This is an example of a completely clubbed and effaced medulla, because it's just this back pressure from the collecting system which has pushed this out. You've got very little contrast. You can only see the contrast on the sides. Can you see that?
Yeah.
So this is complete effacement, and where you've got partial effacement centrally, the contrast then fills in the rest of the space, and you get this sort of signet ring appearance that you've got there. Now, this is a example of the same thing. We've been through this, but this is an overview again. So where you've got clubbed calyces, clawed sign, and the peripheral signet ring sign, and these are features of papillary necrosis. So whole list of causes, but generally speaking, there's a mnemonic, which is postcards, and I'm sure you know it, but pyelonephritis is important. And the take-home message here, that more than 50% of the cases of renal papillary necrosis are related to diabetes. And diabetes is fairly common, so it's not an uncommon finding, and it's a very common question, therefore, in the fellowship exam, and has been asked on a regular basis. Right, so we're now going to go on to our next slide. There is a differential in Chapman, and you can refer to our chapter which talks about causes of bilateral and unilateral renal papillary necrosis, and the type of necrosis, i.e. central fornicel fragmentation, is dependent upon the type of pressures that are placed on the collecting system itself, the concavity of the calyx. If the pressure is sustained, then this will push out and then cause a necrotic effect within the central medulla. And so this is what we've just described. Now we're going to move on to nephrographic patterns of enhancement. So where we've got a CT three-phase study. This is plain, arterial, and this is a venous phase study. And this is just a repetition, just so that we're all familiar with our nephrographic phases and patterns of enhancement. You can see that there's no distinction between the cortex and the medulla. Here there is a distinction between the cortex and medulla, and here you can start to see a filling in of the medullary pyramids, which will eventually go to the excretory phase and start to pacify the collecting system, as you can see here. Now, this is something that is more and more used. Are you familiar with something called the, in CT imaging, we use the split bolus phase? Do you know what that means?
Yeah, so you give one bolus of contrast, and then after a delay, give a second bolus of contrast, and what you should end up with is both an excretory phase as well as a sort of delayed portal venous phase.
Yeah,
imaging within the same study.
Exactly. And what's the advantage of a split bolus?
My understanding was that you get essentially both, you can garner information from both sets of phases but within one image, rather than radiating the patient twice to get the same information. Yeah,
no, absolutely right. So so the advantage is that you expose the patient less. You get two phases in a single acquisition, and the way, as you say, for instance, if you were to do a CT plane and a CT urogram, here we've got a CT urographic phase. Just prior to the urogram being done, 70 seconds before, we give a bolus of contrast again. You can see the portal vein pacified, so you've got both the excretory phase as well as a venous phase of pacifying the kidney. So it's particularly useful for trauma and younger patients where the exposure is important. Now, please talk me through what you see here.
Okay, so on these selected IVU images, just working through them on the immediate film, I cannot see any definite contrast opacification. On the 5-minute delay, there is some filling of the left pelvic calyceal system, but not of the right, and this is a persistent feature as we go through the 10 and 15-minute delayed images. There, on the 15-minute delayed image, there does appear to be some contrast within the urinary bladder, but still no contrast is seen within the right kidney or right ureter. So I would be suspicious of, in the right clinical history, an obstructed right kidney. I think that it is still there. I can make out a renal shadow on the first image. So yeah.
So the kidney, correct. The kidney is there. So your suspicion is of an obstructive uropathy, is it?
Yes.
So what would you do next then?
I would probably ultrasound the patient.
Okay, what else could you do?
I don't think there's any value in doing an extra delayed image.
Okay, no, I agree. So, so basically, the take-home message is that the IVU, essentially, if you've done an IVU, you've got a whole series of sequences there. You know that there's a delayed unilateral nephrogram that you can see on the right side with no excretory phase demonstrated, and therefore, as featured here, the red arrow points out the obstructive uropathy as a cause for unilateral delayed nephrograms. There are patterns of nephrographic change that you need to be aware of, where you've got an absent nephrogram. Obviously, you could have no kidney. There may be global segmental ischemic change to that kidney. But essentially, there are three phases for everyone to be aware of. There's the corticomedullary phase, nephrographic phase, and then the excretory phase, which we all need to be familiar with. I won't dwell on this because this is can be referred to in Chapman, and I invite you to do that.
We have to now. Oh, sorry, I cut you there. You continue with your description, and then we will invite the next candidate.
Thank you, Dr. Khan. So I was just going to say the other nephrographic patterns, just very quickly. You can have a striated nephrogram. Remember the striated appearance of the renal medulla that we've described on the anatomy. You can get a similar effect in acute pyelonephritis as the infection backtracks into the renal medulla, and that gives you a striated appearance, which is very important to be aware of. And the other examples of striated nephrograms are due to sponge kidney, dystrophic calcification, and polycystic kidney disease. But I'm not going to dwell on this, and these are features that we can you can refer to in Chapman.
Okay. Candidate 3 is with us now, and thank you, candidate 2.
Thank you.
Thank you.
Hello. So, uncontrolled hypertension. These are 4 axial images of early phase contrast CT. I can see that the right kidney is hypo-enhancing in comparison to the left side. I can also see it's relatively smaller in size in comparison to the other side. Given the history of uncontrolled hypertension, I'm suspecting that there is a right renal artery stenosis, which I cannot appreciate on this.
Okay, so so we've got uncontrolled hypertension. So essentially, we've got a normal contrast phase on the left side, and you've got the early corticomedullary phase. Here on the right side, you've got poor enhancement. So hyper-enhancing, as you say, but I wouldn't say that term. I would just say that there's a lack of enhancement, or a nephrogram which is slightly delayed. It's smooth outline to the kidney, and the kidney is smaller than that on the right side. So the features are therefore of something called renal artery stenosis. So there's reduced renal arterial inflow, and that's causing the nephrographic pattern that we've just seen. So these are the other patterns, again, that you can refer to in Chapman. Renal causes of hypertension. Renal artery stenosis is an important cause of renal hypertension, and again, that's important. Renal artery stenosis and the specifics, please refer to Chapman again. I'm an interventional radiologist, and we stent renal artery stenotic lesions from FMDs in young patients and atherosclerotic disease in older patients, and it's not an uncommon finding. So, very briefly, what do you see in this fiver film?
I can see a striated left nephrogram.
Okay.
Might be infarctions, might be pyelonephritis.
Okay. So why is it not pyelonephritis?
Because there is no enough fat stranding surrounding it.
Exactly. So the lack of fat stranding around the left kidney probably takes that out of the equation. Is this a typical pattern for pyelonephritis? No, it isn't. You don't tend to get this. What else can you see on the image here? Tell me about the renal artery and the aorta.
Yeah, I can see a calcific plaque, and the aorta is also atherosclerotic.
Okay.
It's not the ideal window, but I think there is a large calcific plaque at the origin of the left renal artery.
Okay, so I would, I'm not sure whether I can see what you mean, but there's certainly a significant area of renal artery stenosis demonstrated within the proximal left renal artery with pre-stenotic dilatation, and the features of those of renal artery stenosis and multi-segmental infarcts of the left kidney as a result of reduced inflow. Now, this is another picture. Just tell me what that shows.
So this is a coronal MIP image of an CT or MR, CT angiogram.
So is this a CT angiogram in your opinion?
I can see what appears to be like aortic plaques, calcific plaques. I don't expect these to appear on an MRA.
Okay. So let me just stop here. This is an MR angiogram. This is a MIP, and this is showing a focal occlusion of the right renal artery, approximately 1.5 centimeters from the renal ostium. Okay, so it's a MIP and it's MR. This is another MIP, but this is from a CT. What do you see?
I see corkscrew spiral appearance of the right renal artery.
Okay.
Maybe small aneurysms or pseudoaneurysms from the middle segment of the right main renal artery.
No, I would disagree with that. I mean, yes, you've got a spiral corkscrew appearance to the mid portion of the right renal artery. So that appearance by itself would suggest a multi-segmental. So I'd be very careful about using terms like corkscrew. You can use them, but it's better to use a descriptive analogy before, just to say that this multi-segmental narrowing of the mid-right renal artery in a patient that otherwise has a smooth outline to the aorta and the iliacs. And that indicates to you that you've got a fairly normal vascular system elsewhere, but there's a focal area of disease, and that therefore denotes something like FMD rather than renal artery stenosis, which is seen in older population. What do you see here?
So this is a digital subtraction angiogram through the upper limb. I can see tight stenosis of both renal arteries, but more severe on the left side.
Okay, so how do you know it's tight? How can you use that terminology?
So I can see some collaterals around the stenotic segment on the left side. I cannot delineate the residual lumen itself.
Okay, so I think again, refrain from using that terminology. So what tight you can't say, because what you can say is that there appears to be a high-grade stenosis in the proximal right renal artery, and there appears to be a rather fibrillated stenotic focus within the left renal artery. So the terminology here is crucial in terms of what the pathology is. And here indeed you've got bilateral changes within an aorta. The aorta as a whole on a background, so this is important, you say bilateral renal artery stenosis on a background of an ectatic aorta. Okay, so this could be FMD or this could be renal artery stenosis, but in this case, this was bilateral renal artery stenosis in an older patient. Tell me what you see in this Viva image.
So I can see what appears to be a horseshoe kidney with a central non-enhancing isthmus. I wonder if this is a trauma patient or not.
No, so there's no history of trauma. There's just a history of intermittent visible hematuria.
All right. So there is the isthmus of the horseshoe kidney is non-enhancing. I cannot see evidence of stones, back pressure, or any masses.
Okay, I'll stop you there. So here, what you've got to look at is you've got continuity of a low attenuation lesion within the isthmus of the horseshoe kidney. It appears not to be involving the, so what's important again, description. So you've got something that appears to be cortically based, does not appear to be arising from the collecting system on either side, and appears to be causing local mass effect. Do you see that? So the presence of local mass effect within the isthmus of a horseshoe kidney, until proven otherwise, is a malignancy, and that's an RCC. Tell me about this case.
So I can see a hypoenhancing.
So I'm going to stop you straight there. Your description also needs to account for the CT as well. So what you can say is there is a series of CT axial images of the upper abdomen, and then so very quickly you say not I can see, because that doesn't give us the examiner an idea of what you can see. Please come on.
These are axial images of contrast enhanced CT of the upper abdomen and lower chest. There is a hypoenhancing right renal mass as eccentric in location. I can see it's invading the right renal vein and extending into the IVC up to the right atrium. I can see renal cysts on the contralateral side. So in conclusion, this is a renal cell carcinoma with extensive venous invasion.
Okay, good. So as you say, you've got a large renal mass arising from the posterior interpolar region of the right kidney. Remember, be descriptive, very important. It's causing blunting and local mass effect and splaying of the calyces, and there is extension into the right renal vein, IVC, and possibly retrograde involvement into the left renal vein, which is important. The IVC is distended. The IVC inside the sort of intrahepatic region is also dilated. There is free fluid seen anterior to the liver, and there is right atrial invasion. Right. Solid renal masses we've just described, and we've just talked about renal cell tumours, and this is another differential list in Chapman that I refer you to. Now we're going to go on to long cases now.
So, Imran, you need help?
I'm just trying to, this isn't sharing.
Okay, so help is on the
Okay, lovely. So now I'm going to describe some long cases, and thank you. So we're going to be talking about a tumour with enhancing tumour thrombus extending into the IVC. So this is an example of this, the sort of effects that a renal cell tumour can have, and this is what you should be looking out for. So look at the phase of contrast, and there's an arterial phase that you can see, and there's arterialization, if you'd like, of the IVC with heterogeneity of enhancement. There is local mass effect from the enlarged IVC, and this continues into the right kidney. So you can see this effect here. It almost looks like a secondary IVC, doesn't it? You've got the aorta, IVC. So as you're moving from north south, there's some low attenuation change at the interface of the left renal vein with the IVC, and then this dilated focal area of bulbous renal vein enhancement appears to be contiguous with an area of pathological change within the right kidney. Now, as we move on, we can see the same effect of the same patient on a coronal image, and you can hopefully see that there is extension of a filling defect and heterogeneity within the intrahepatic IVC. And remember that if you've got this change within the region above the level of where the renal veins meet the IVC, then there is likely to be retrograde filling, possibly off the contralateral side, and you can see that there. Also, have a look at this. This is the IVC backfilling into the renal vein, which is dilated. And if you follow this through, the beauty is that this will almost take you to the area within the kidney that has a tumour within that. You see that? So the renal tumour has a lip which extends into the renal vein, which then becomes expanded and then features into the IVC. Are you able to hear me?
Yeah, I can hear you very well. Yeah.
Okay, so right, so that's the feature that we can see there on the CT. So that's axial and coronal. Now this is a T2 weighted MRI sequence, and you can see that there is a filling defect which is seen within the IVC. Now this extends to the level of where the left renal vein is, but now you can see that the artifactual filling defect that we were seeing at the level of the left renal vein is no longer seen. So that may well have been admixture artifact in the context of tumour involvement of the renal vein. And as you come back in, you can see the tumour just here. This is the same patient coronal image on the MR sequence. And again, that shows that nice streaky artifact with a broad funneled mass effect within the renal vein and the renal vein dilatation, which then, if you just follow through, it's here, will take you to the mass that you can see just there within the kidney. Do you see that? So this is a very nice long case which will show you the characteristics of a renal mass both on CT and MR. This is a post-contrast enhanced sequence, and it shows enhancement of the kidney as well. Now we're going to go on to a next case. This is another long case that could come up in the exam. So we notice a left kidney. We notice the absence of the right kidney. So whenever you see a CT image where there's no right kidney, you've got to question whether they've had a nephrectomy. But in this context, you suddenly see this lobulated low attenuation change adjacent to and contiguous with the left kidney. And that appearance there is largely cystic. You see a high attenuation area posteriorly, which could be a stone. And then that's contiguous with this tubular structure, which crosses the midline and comes further south. So what's going through your mind at the moment?
Cross-fused ectopia.
Yeah, so cross-fused renal ectopia with a normal appearance to the left kidney, i.e. the contralateral kidney is normal. You've got this possibly burnt out, cross-fused right kidney, which is fused with the left kidney. You see this hydroureteral nephrosis, and the ureter comes down and it's very dilated and then enters this structure here. So what do you see inside the bladder?
Maybe it's a large urethrocoel, I think.
Yes, very good. So you've got a large urethrocoel, which is causing a filling defect and back pressure and obstruction to the right kidney, and equally can cause, for the record, an obstruction to an upper pole or lower pole moiety. Adjacent to this, you've got this structure, which is a
Urinary catheter.
urinary catheter, and you've got some air within the ventral bladder lumen, and that's obviously due to bladder instrumentation. So a nice case of a large urethrocoel and the consequences of that in terms of causing cross-fused renal topic obstruction, as we've just seen here. Okay, so this is the same patient, and I just want you to have a coronal image of this. In your mind, you can see that collection of cystic change. The important feature here is that it has to be contiguous with the other kidney, which it is, and also the ureter quite often is on the correct side, which it crosses over, and you can see it crosses over onto the right side, and follow the ureter down, and then you can see the urethrocoel in profile on the coronal cuts there.